In this lecture, we are going to learn about nephrotic syndrome in pediatrics. Let's look at normal features that we see in nephrotic syndrome. We see massive proteinuria, and this is usually more than 1 gram per meter square per day. Along with it, we also see hypoalbuminemia, which is usually less than 2.5 grams per deciliter. We see generalized edema as well as hyperlipidemia. We can also see some nephritic syndrome features such as hematuria as well as hypertension. So in about 10 to 20% of cases, we also see hematuria as well as hypertension, which are mainly the clinical features of nephritic syndrome. So these are the features of nephrotic syndrome in pediatrics. The hypoalbuminemia is due to, what happens is, the hypoalbuminemia induces hepatic synthesis of lipoproteins, and this leads to hypercholesterolemia. So hypoalbuminemia induces hepatic synthesis of lipoproteins, and this leads to hypercholesterolemia. And this is the reason why we are seeing hyperlipidemia in the nephrotic syndrome patients. When it comes to childhood nephrotic syndrome, 90% of the cases will be primary or idiopathic. So the 90% of cases will be primary or idiopathic, while only the other 10% will be due to secondary causes such as amyloidosis. Then it can also be occurring on the background of vasculitis or SLE, in the background of PSGN, that is the post-streptococcal glomerulonephritis, which is a part of nephritic syndrome features. It can also occur in the background of hepatitis B nephropathy. So you need to know that 90% of the cases are primary or idiopathic, while only the 10% cases will be secondary to diseases such as amyloidosis, vasculitis, SLE, PSGN, as well as hepatitis B nephropathy. So when it comes to nephrotic syndrome in children, we can divide the category into two different lesions, that is a minimal lesion or minimal change disease, or other significant lesions that are more common in the younger adults. So these are all the bases in which we will be dividing the lesion. When it comes to minimal lesion, the age of onset will be 2 to 6 years. While other significant lesions, this occurs in older children. Sex, minimal change is more common in higher incidence is seen in the boys, while it is equal between boys and girls if it is significant lesion. When it comes to hematuria, this is rare in minimal lesion, while this is usually seen when it is a significant lesion. When it comes to blood pressure and GFR, both are normal in minimal lesion, while they may be normal or it may be raised in significant lesion, and GFR might be normal to reduced in the significant lesion. When it comes to proteinuria, it is usually very high in the minimal lesion and it is very low in the significant lesions. And following treatment with steroid therapy, more than 95% cases will undergo remission, whereas the steroid treatment is unsatisfactory when it comes to significant lesions. So these are all the categories that we can divide the nephrotic syndrome in pediatrics. It can be due to minimal lesion or significant lesions, and this is how we can differentiate both of them. Now we will move on to the characteristic, that is steroid sensitive nephrotic syndrome. It is also called as minimal change disease. Minimal change disease, MCD, or it is called as steroid sensitive nephrotic syndrome. This is most common in 80% of cases of nephrotic syndrome in the pediatric group. When we look at the light microscopy feature of the kidney, we are going to see nothing. But when we look at it under electron microscopy, that is when we see obliteration of food process of podocytes. And on immunofluorescence, sometimes we see IgM deposition in the mesangium. IgM deposition in the glomerular mesangium. Okay, this is the minimal change disease or the steroid sensitive nephrotic syndrome. Now let us learn about clinical features of nephrotic syndrome in pediatrics. So the patient or the child will have generalized edema. The patient will come with generalized edema, or the mother will tell that the patient is having periorbital swelling. So we'll first look at the eyes. First it will appear in the eyes, then it will move on to the legs. And this edema is usually soft and pitting. Okay, and this is usually followed by the child can have ascites, the child can have hydrothorax as well as hydrocele. Okay, now as and when this edema increases, the child's urine output will slowly decrease because of declining GFR. Usually the BP will be normal initially, but slowly it begins to increase with significant glomerular lesions. So these are the clinical features associated with nephrotic syndrome in pediatrics. Moving on to important lab findings that we see in nephrotic syndrome in pediatrics. Firstly, we will do urine examination. In urine examination, we are going to see 3 to 4 plus proteinuria on dipstick method. 3 to 4 plus proteinuria on dipstick method. We can also see gross hematuria, or we can see microscopic hematuria when we do urine routine and microscopy. Microscopic hematuria. In the urine routine and microscopy, we can also see hyaline and granular casts. The next examination that we can do is CBC. When we do CBC, as well as we can also look for LFT and RFT. In this, we look for the blood levels of urea and creat. So when we look at the blood levels of urea and creat, these levels are usually normal in early cases. So they are normal in early cases, and they may be deranged if the patient has significant lesions. Okay, then we look at the albumin levels. When it comes to albumin levels, it is generally less than 1 grams per deciliter. We can also look at the levels of cholesterol. So generally it is raised and the plasma will appear milky. So we see milky appearance of plasma due to raised cholesterol levels. So this is what we see in CBC, RFT and LFT. We can also examine the patient for the third test that we can do is tuberculin test, because even tuberculosis can induce nephrotic syndrome in children. The fourth investigation we can do is if the patient has persistent microscopic hematuria, then we can look for complement 3 levels in the blood. If they are reduced, then it indicates that they are depositing in the glomerulus. And we can also look for ASO titers, that is anti-streptolysin titers, which indicates the infection of PSGN. The fifth investigation we can look for is a chest X-ray. If the patient has positive tuberculosis test. Then if the patient has a recent incidence of jaundice, or if we are seeing raised AST bar ALT, then we can work up for HbA1c antigen in the blood, or supposedly infection from hepatitis A or hepatitis E. If we want to look for the secondary cause such as SLE, then we can order anti-nuclear antibodies. Then if we are suspecting UTI, we can call for urine culture as well. So these are all the basic investigations that you will do when a patient you are suspecting he has nephrotic syndrome. We can order for an urine exam. In this usually you will see 3 to 4 plus proteinuria. We can see gross hematuria or microscopic hematuria, and as well as hyaline and granular casts. When we order CBC, RFT, LFT, in the renal function tests, we can see urea and creatinine levels. They are normal in early cases and they may be deranged if the patient is progressing towards significant lesions. We can look at the albumin and it is generally less than 1 gram per deciliter. And we can look at the cholesterol, it is generally elevated and it gives a milky appearance to the plasma. We can order tuberculin test if we are suspecting the cause is due to tuberculosis. And if the patient has persistent microscopic hematuria, we can order for the complement 3 levels. They will be generally reduced in the plasma if they are going and depositing in the glomerulus. We can also order for ASO titers if we are suspecting PSGN. We can order for an X-ray if the tuberculin test has come positive, and if the patient has recent history of jaundice as well as elevated AST bar ALT levels, we can order hepatitis panels, HbA1c, hepatitis E and hepatitis E. If we are suspecting that it is due to secondary causes such as SLA, we can order for anti-nuclear antibodies. And if we are suspecting UTI, you can order for urine culture as well. Let's look at indications of renal biopsy. So, in our patient, even after doing all this, if you are unable to confirm, then we can go for renal biopsy. So, before ordering a renal biopsy, we need to know what is the indication that absolutely necessitates the need for renal biopsy. The age of the child must be less than 12 months. Age of the child less than 12 months. Or if the child has gross or persistent microscopic hematuria even after starting the treatment. Gross or persistent microscopic hematuria. Or if we see low blood concentration of complement 3 levels, which indicates that they are going and depositing in the glomerulus, necessitating the need for renal biopsy. Or if the patient has hypertension with impaired RFT. So impaired RFT means that the patient's GFR is going down and we need to know why. That's why we need to perform renal biopsy. Finally, if the patient is unresponsive to steroids. When the patient is unresponsive to steroids, that's when we need to think that A patient has a significant lesion other than the minimal change disease, and we need to start the treatment accordingly. So these are the 5 indications for renal biopsy, that is age less than 12 months, gross and persistent microscopic hematuria, low blood complement 3 levels, hypertension with impaired RFT, as well as unresponsiveness to the steroids. In the next video, we are going to watch about the management of the first episode of nephrotic syndrome in the children. Thank you for watching. Bye.